So we have some time left. It's an opportunity for you to ask questions. There's a question there just on the side. Careful to talk into the microphone so everybody can hear.
I used to work at IBI for 20 years, but that's another story. Just to the distinction between a total, between the 100% blockage and angina. I mean, did our two guests did they have a total blockage? Total, so there was no blood going through. But they were conscious. They came in, they walked in, they came in by taxi. So they were still, I'm just a bit confused between severe angina with maybe 90% block and what happened to them.
It depends very much where the blockage is. So in both cases, it was not at the proximal area. So when it's really early on at the big area of these arteries, very often you don't survive that. So around 40% of patients who have a blockage in the proximal areas pass away.
Right, I've got a question to ask. Would a Mediterranean diet help with your lifestyle?
Which diet?
Mediterranean diet?
It will definitely, yeah. So this is one of the recommendations that we have patients on Mediterranean diet, the olive oil especially, the vegetables, and not too much meat. Yeah, that's a big part of the diet that we recommend.
The research that you're doing for the CATs, CT calcium deposit, is that a similar type of investigation that the cardiac selling for $800 a pop, at those ones?
So a CT scan is an X-ray scan of the heart, and I don't know exactly what you have in mind, but
they measure the calcium deposit of your heart.
Yeah.
Is that a similar thing?
It is a similar thing. Yep. So what we're interested in doing is identifying how that fits into the whole preventive strategy. Who should have that? Is it just people that can afford $800? Or is it a particular group of people who are at risk? And you've heard from Karl-Heinz how to recognize the problem when a problem starts, but we're also interested in trying to reduce the likelihood of that problem happening in the first place. And so our studies are designed towards identifying of people with a family history of coronary disease, who are the ones who are at risk and how should they be managed. So if anybody has a family history of coronary disease here or knows somebody, then we're interested in talking to them about that study, but that's specifically what we want to do. Go ahead.
My question leads on from that. I'm 71, so there's one risk. Age, my father in his 40s had 2 heart attacks, so there's another risk. But I've now got chronic lymphocytic leukemia. It's only stage 0 and it's not progressing. But my question is, has the research found anything between leukemias and heart disease?
No, not really. There are links between some blood diseases and heart disease, but that particular sort of leukemia that you have, not really. In some other leukemias and lymphomas, some of the treatments that we give for that can produce heart muscle disease, not artery disease. But in your particular case, these are diseases that start being a problem in the 70s, and sometimes they just overlap. I don't think one has led to the other. There's a question in the middle, I believe.
Some years ago, I attended a similar lecture given by a heart specialist. He mentioned all the preventative measures that you have this evening, but probably just added one, which is associated, I suppose, with government policy and information for consumers. He made the point that in Europe and America, trans fats are labelled, and it is pointed out that the avoidance of trans fats and their role in developing plaque, whereas in Australia, no such labelling is required, and no public information in supermarkets, etc. So I'm wondering about a greater role of government labelling policies, not just for trans fats, but for other dangers.
Yeah, this is an important point. The reason why this is an epidemic relates to how we live. And in fact, that's the reason why in the developing world, it's said that there's an epidemiology of disease that's in transition from people dying from infections and from injuries to dying from Western diseases because we've exported our lifestyle. So yes, government policy is part of what we're about, and we at Baker do interface with government about that. We didn't put it in this evening because we thought that we should target this discussion towards what people can do themselves. But there's no doubt that there is a big story there. Unfortunately, there are often conflicting interests. The food industry obviously is very powerful, and there's a lot of economic interest behind it. So it's a big story. Maybe we should run a session on that, honestly.
Just another comment to this. It's when you look in the US, for example, there was a big campaign against cholesterol, and so all the cholesterols are labeled now, which was very successful because a lot of the food all the things that you can get in grocery stores have a label now, and people are very aware of cholesterol content. But what has happened was that glucose took over, so all the sugar that is now in a lot of the foods that you can get. And this is a good example where we as the baker try to lobby the government that we should be careful what kind of soft drinks we offer, especially in schools, and to make sure that obesity is not becoming the next big problem.
Any other questions or comments from the audience?
Hi, Caroline.
Go ahead. Yeah.
Just going to ask, I have been told that if we cough forcibly when we suspect we're having a heart attack, that is helpful. Is that true?
It's a very unusual approach.
But taking deep breaths and coughing with great vigour, so that you're coughing out and pushing the muscles in the chest.
If you have a cardiac arrest, it's probably too late to do that. And if you have just chest pain, it wouldn't really help you much. So there are some specific rhythm problems that you can potentially solve with it, but we wouldn't really recommend it for patients to do it.
Question at the front.
I'm Deb, so I hope you excuse me. I was just wondering, is it a good idea to take an aspirin tablet if you think you're having a heart attack, if you're in the car or something like that? Is that advisable?
Yeah, that's one of the medications that we would advise, definitely, to take an aspirin tablet right away and then contact, 000 or, yes.
Sort of following on from that, I was wondering about taking cardiac, I don't mean to mention the brand, I don't know choice, that low dose aspirin every day as a preventative measure. Like, it seems to be a good idea. I take it myself. What do you think of that?
There's a big controversy around this. So the disadvantage of taking aspirin is that there is a slightly increased risk of having a cerebral bleeding, so developing a stroke. So this is kind of a risk-benefit assessment that you have to take, and it's probably if you have one or two risk factors for coronary artery disease, we recommend a lot of patients to take aspirins if they don't have specific bleeding problems. And in the US, for example, when you look at physicians, there are a lot of them after 45 or 50, they take aspirin even if they don't have any risk factors. So it's a very good approach, I think.
Thank you.
Go ahead, please.
I recently had a pacemaker inserted following the diagnosis that the chamber of the heart is not working properly through lack of protective impulse. Did I have a heart disease, or do I have just a heart malfunction?
In case people didn't hear at the back there, this is a question about use of a pacemaker and whether it was a heart malfunction or heart disease. So the heart has an electrical system which drives it, and there is a risk of that system breaking down. So sometimes there can be a conduction problem from where the impulse arises to where the pump is, and a pacemaker will bridge that. And sometimes the actual impulse doesn't arise at all. The heart's own pacemaker doesn't work. So a pacemaker is generally about those electrical problems. Now, they can occur secondary to another problem. In some sorts of heart attack, a pacemaker is needed because of those kind of electrical problems. But usually that's not the case. It's usually a separate process. So it is a type of heart disease, but it's an electrical heart disease rather than a plumbing sort of heart disease. Okay. Question at the back. Yes, Jack.
How are heart attacks different to strokes? What are the symptoms and how should we respond?
So a heart attack is a blockage of one of the coronaries, as Karl-Heinz mentioned to you. A stroke is a problem related to one of the arteries that feeds the brain, or a blood clot that has broken off and gone up to the brain and blocked off the supply to the brain. So a heart attack, typically problems with chest pain or sweating or shortness of breath or cardiac arrest, blackout. A stroke is more weakness, numbness, difficulty talking, troubles with balance. Both of them are an emergency. Both of them require a trip to the hospital and some investigations to find out what the problem is, and sometimes some kind of intervention. So they're a different set of symptoms, but they relate to the same or very similar process happening in two circulations, and they both require urgent attention. One of the things that delays people, when Karl-Heinz and I talk to our patients who come to the hospital with these problems and they're delayed, they often say, well, I thought that there was something wrong, but I felt, I kind of didn't want to disturb you, or I didn't think it was really a problem. I've never seen any doctor get frustrated with a patient because they've come for chest pain or an unexplained symptom. If you have one of those symptoms, nobody is going to be annoyed at you turning up to the emergency department. If there's no problem, everybody's happy. You're happy, the doctor's happy, the nurses are happy, everybody's happy. So don't hesitate. If you have those symptoms that we've spoken about tonight, it is an important sign that you need to have attention. It may not turn out to be anything, but it could turn out to be something really important.
I can probably speak down. Just to ask if ischemic heart disease is the same as coronary heart disease, or a different thing?
So ischemia refers to the problem of perfusion, which is typically caused by coronary artery disease.
Karl-Heinz, you mentioned the clot busting drug that you're working on. Would that be relevant to treat a stroke as well?
So it's actually, when you look at the indication, it's probably the bigger field of where we need a good clot-busting drug, because when you have a stroke, there's a really short window where we can help people. And it's not as advanced as in cardiology. There is a new development where we go into the brain and try to get out the clots with instruments, but it doesn't work as well as it does in the cardiology field. So if we are not fast enough, if somebody has a stroke, and if we can't give these clot-busting drugs, then the consequences are really catastrophic. And so there it's really a big indication. And a lot of trials have been done with new drugs, but so far there's no reliable clot-busting drug around, and therefore this is one of the big developments that we try to push forward at the Baker.
Go ahead.
Is development of plaque, is that reversible?
That's a big discussion point. So it's probably not massively reversible. So if you take statins, if you have a healthy lifestyle, what you can achieve is probably that you stabilize the plaque, and that's already a big success, because there is not the risk anymore that it ruptures and causes a blood clot. And so when you kind of transform these unstable inflamed plaques to stable plaques, I think then as a patient you should be okay, and that's what we would like to achieve with statins and hopefully newer drugs that we are developing.
Probably the last question over there. Go ahead.
Regarding the stents that you were talking about, are they permanent cure for that, or do they re-block up, or do they block it like the rest of them, or are they permanent cure for that?
Yeah. So there's a lot of development in these stents. Initially they were just metal stents, and we realized that there's a lot of regrowth. It's like when you kind of scar a tissue, then the scar very often grew, and this was the case in around 30 to 40%. And then we discovered that certain drugs on the surface of these stents prevent this regrowth, this scarring. But we now have to be careful that we don't have a thrombosis. So when we insert these metal pieces with the drugs on top, we give 2 drugs, 2 blood-thinning drugs, so aspirin and an additional new drug that we have, and that has to be given for a year. Then typically the stents are totally incorporated into the tissue, and they can stay there for the rest of your life. So they are very stable. It's a very durable metal. And so that works out quite well. But we also have new developments where we have stents that dissolve over years. So that's a lot of development in that area, and it's very fascinating. If you see the initial stents that we had were kind of bulky and difficult to employ, and the technology has advanced really substantially in that area.
One extra question in the middle. Go ahead. Yes.
I was curious. I've got a friend who has had all those symptoms of a heart attack quite a few times, and gone to emergency, and they've done the troponin test, and they've done the ECGs, and he's been sent away again. And I was just wondering, how conclusive those were. It does seem to be, it's occurred 6 or 7 times in the last 12 months? Or, is it just that there's probably something else that's wrong?
As Karl-Heinz showed you in one of those slides about the distribution of pain, the body's not very clever about apportioning pain from the heart. So it can be mimicked by a number of other organs. So the gullet can produce pain in exactly the same territory, the esophagus, the gallbladder, the stomach, and so on. So sometimes there's completely another process that is driving this. And then there's another group of people who actually are having heart pain but don't have a blockage in the artery. Their blood vessels are more reactive than other people's blood vessels. So it's not that it's a clot that's blocking them off, it's just that the muscle is tightening up and preventing the blood flow. So this is a very active area of research about how we should go about diagnosing these problems. But still, even in those circumstances, if there's ambiguity about the nature of pain, it's best to get it to come to the emergency department. Okay, I think we're running out of time. Karl-Heinz, thank you again. I thought that was So, as you know, this institute is an independent institute, and what we do is supported by the community. It's supported by our scientific grants from various bodies, including the National Health and Medical Research Council and the Heart Foundation, and it's supported by our commercial partnerships with industry. But the community's support of what we do is extremely important, and if you're interested in what we do, we have a book that you can leave us your details, or you can talk to some of my colleagues who will be around afterwards. If you feel that you would like to give something to support us tonight, we'd be very grateful for that as well. So please pass the message around. I hope that you've benefited from tonight. I think there were a lot of questions from the audience. I have a question for you. How many of you can do CPR? Hands up. Okay, so it's easy to learn this, okay? So you can learn this from the Heart Foundation or the Red Cross. This is something that is potentially life-saving. So pass the message around that Baker IDI has a role here in reducing the burden of disease. I'd like to acknowledge our sponsors, the Art Series Hotel Group and the Cullen, and I'd like to thank all of you for coming along tonight. Thank you.